Welcome to our comprehensive guide on respiratory auscultation. Auscultation is a fundamental clinical skill that allows healthcare professionals to evaluate air entry and detect respiratory pathologies simply by listening to lung sounds over the chest wall. The sounds you hear are produced by airflow through the respiratory tract, and they can vary significantly depending on whether the underlying tissue is healthy or affected by disease. In this video, we'll explore the basics of normal and abnormal breath sounds, discuss the clinical technique for auscultation, and provide practical tips for accurate assessment. Let's begin by understanding what makes this skill so essential in clinical practice. Normal breath sounds are heard over healthy, patent lung segments. These sounds are influenced by individual anatomy, such as chest wall thickness and subcutaneous fat, which can affect how sounds are transmitted and their overall quality. Understanding what is normal is the foundation for identifying abnormal findings. In the next scenes, we'll break down the three main types of normal breath sounds: vesicular, bronchovesicular, and bronchial. Each has distinct characteristics, locations, and timing within the respiratory cycle. Let's start by exploring vesicular breath sounds. Vesicular breath sounds are soft and low-pitched, typically heard over most lung fields, especially in the peripheral regions. These sounds are present throughout inspiration and only at the beginning of expiration, with no pause between the phases. Vesicular sounds are considered the baseline for healthy lung function. Recognizing this pattern is crucial, as deviations may indicate underlying pathology. Next, we'll compare these with bronchovesicular breath sounds, which have a slightly different quality and location. Bronchovesicular breath sounds combine qualities of both vesicular and bronchial sounds. They are best heard over the main stem bronchi and are especially prominent in thin individuals. These sounds are heard equally during both inspiration and expiration, with no pause between the phases. Recognizing bronchovesicular sounds is important, as hearing them in unexpected locations may suggest pathology. Next, let's look at bronchial breath sounds, which are normally only heard over the trachea. Bronchial breath sounds are harsh, hollow, and high-pitched. They are normally heard only over the trachea. These sounds are characterized by a distinct pause between inspiration and expiration. If bronchial sounds are heard outside the tracheal area, it often indicates an abnormal process, such as lung consolidation. Understanding these distinctions helps clinicians pinpoint the location and nature of respiratory pathology. Now, let's transition to abnormal and adventitious breath sounds. Abnormal breath sounds are those heard in locations or with qualities that differ from the expected normal patterns. For example, bronchial sounds heard outside the trachea can indicate consolidated pneumonia or lobar collapse. Decreased or absent breath sounds may be associated with pleural effusion, hemothorax, pneumothorax, emphysema, or even patient factors like obesity or advanced age. Recognizing these abnormal patterns is critical for accurate diagnosis and management. Adventitious, or extra, breath sounds are superimposed on normal breath sounds and are typically heard over unhealthy lung regions. These sounds are divided into two major types: crackles and wheezes. Each type has distinct characteristics and is associated with specific clinical conditions. In the next scenes, we'll explore crackles and wheezes in detail, including their subtypes and what they may indicate about a patient's respiratory status. Crackles, also known as rails, are discontinuous, non-musical sounds. Fine crackles are high-pitched and sound like Velcro being pulled apart. They are often heard in conditions such as atelectasis, interstitial pulmonary fibrosis, or even in healthy individuals at times. Coarse crackles are medium or low-pitched and are usually associated with retained secretions. Recognizing the difference between fine and coarse crackles can help narrow down the underlying cause of abnormal lung sounds. Wheezes are continuous, musical sounds that can be high or medium pitched. They are often described as sounding like blowing into a bottle or a wooden flute. Wheezes are commonly associated with bronchospasm, as seen in asthma, cardiogenic pulmonary edema, or chronic obstructive pulmonary disease, COPD. Low-pitched wheezes, sometimes called raunchy, are usually due to retained secretions in the large airways. Identifying the pitch and quality of wheezes helps guide clinical decision-making. Effective patient communication is essential before beginning auscultation. Always explain the procedure in simple, layman's terms and inform the patient to let you know if they feel lightheaded, dizzy, or uncomfortable. This ensures patient cooperation and safety throughout the assessment. Proper communication also helps build trust and reduces anxiety, making the examination smoother for both the patient and the clinician. Position the patient upright whenever possible to allow for multidirectional access to the chest. Remove or systematically drape clothing to ensure direct skin contact across all lung fields. Proper explanation and professional draping are especially important with female patients to maintain dignity and comfort. These steps are crucial for accurate auscultation and patient safety. When auscultating, never listen through clothing or over bony structures like the spine or scapula. Always listen to a complete respiratory cycle at every site and instruct the patient to breathe deeply in and out through their open mouth. Avoid letting the stethoscope tubing rub against yourself, the patient, or furniture, as this can create distracting noises. Provide rest periods after every 5 to 10 deep breaths to prevent hyperventilation. Begin auscultation at the uppermost anterior points of the chest. There are 4 key sites, 2 located lateral to the lower border of the manubrium, and 2 superior and lateral to the lower end of the sternum. Following a structured sequence ensures that all lung fields are assessed systematically, reducing the risk of missing localized abnormalities. Next, move to the lateral chest. There are 2 auscultation sites on each side, positioned bilaterally on the mid-axillary line at approximately the 4th to 5th rib. This area is important for assessing the lung fields that may not be accessible from the front or back. Consistent technique ensures a thorough evaluation. The posterior chest offers the most comprehensive access to the lung fields. There are 10 auscultation sites, 2 above the midline of the scapula, 2 lateral to the spine of the scapula at T3, 2 lateral to the inferior angle of the scapula at T7, 2 lateral to T10, and 2 slightly lower and more lateral over the lung bases. Systematic coverage of these sites is essential for detecting abnormalities in the posterior lung fields. Hold the stethoscope firmly with the diaphragm directly against the skin. This ensures optimal sound transmission and minimizes external noise. Avoid placing the stethoscope over clothing or bony structures, and always follow a structured, contralateral side-to-side sequence moving downward. These small details can make a significant difference in the quality of your assessment. At each auscultation site, listen to an entire, complete respiratory cycle. This means paying attention to both inspiration and expiration, as some abnormal sounds may only be present during one phase. Instruct the patient to breathe deeply through their open mouth, and provide rest periods as needed to prevent dizziness or hyperventilation. Accurate documentation is vital. Always record the precise term for the sound heard, its location, intensity, and timing within the respiratory cycle. Use standard abbreviations like A, E for air entry. For adventitious or extrapulmonary sounds, specify the pitch, phase of respiration, and exact anatomical location. Clear documentation ensures effective communication and continuity of care. A typical normal documentation entry might read, "Normal breath sounds and E good throughout." This indicates that air entry is adequate in all lung fields and no abnormal sounds were detected. Consistent, clear language helps other clinicians quickly understand your findings and supports high-quality patient care. When documenting abnormal findings, be specific. For example, decreased breath sounds over basses bilaterally, or fine end inspiratory crackles heard over lower lung fields bilaterally. This level of detail helps guide further investigation and management. Always include the location, quality, and timing of the abnormal sound. For extrapulmonary findings, such as a pleural rub, documentation might read, end inspiratory pleural rub heard over left lateral base. This describes a sound that resembles leather rubbing together, indicating involvement of the pleural surfaces. Accurate, descriptive documentation is essential for multidisciplinary communication and effective patient management.